Hello and welcome. Today we're going to discuss depression pearls for pediatric providers. My name is Dr. Laura Markley, and I am board certified in pediatrics, general psychiatry, child and adolescent psychiatry, and addiction medicine. Let's start by discussing how depression can be different in pediatric patients. In children, instead of kind of the classic down and depressed mood, they can be irritable. The most important thing is to think, is this a change from their baseline? If a child's been irritable since day one, it's probably not a major depressive episode. Children are less likely to verbalize symptoms. Emotions are very abstract concepts, and children are often very concrete. This makes it very difficult for them to explain what's going on the inside. They express their distress through behavioral challenges and often somatic symptoms. Behavior changes can be becoming either more withdrawn or more aggressive, having temper tantrums and being more argumentative. Somatic symptoms are very frequent with both depression and anxiety and include headaches and stomach aches. What do we mean when we say someone has mild depression? We mean that that individual is not having any suicidal ideation or self-harm behaviors. They're not expressing any psychotic symptoms. Anhedonia, or the feeling of just kind of having the blahs, not really wanting to do anything, not having joy from anything, is not prominent. Hopelessness is not prominent. And supportive therapy for those patients may be sufficient. Psychoeducation about how to monitor for worsening symptoms, managing their environmental stressors. For instance, if there's a large contribution from issues with school or grades, getting the parents on board and how to mitigate those things, and really have them come back in 4 to 6 weeks to see how they're doing. If they're doing worse, then obviously we're going to consider a more robust treatment plan. The biggest thing to take away from our discussion for moderate to severe depression, which is to make it very easy, anything other than mild depression, if you add a little something into any suicidal ideation, any perceptual disturbances or paranoia, any self-harm, anything like that, you're going to move into the category of moderate to severe depression. And the most important thing to take away from the treatment of moderate to severe depression is that the most effective treatment includes medication or the combination of medication and therapy. Often in the clinics, we'll use a depression screener, such as the PHQ-9, the version of which I'm showing has been modified for use in adolescents. In addition to being a screen, the PHQ-9 can be used as a diagnostic aid for major depression or depressive disorder. In order to call someone the diagnosis of major depressive disorder, you have to have questions 1, which is, have you been feeling down, depressed, irritable, or hopeless? Or question 2, which is, have you had little interest or pleasure in doing things, endorsed as a 2 or a 3. Then you need 5 or more positive symptoms as defined as a 2 or 3 in the following questions, and by a 1, 2, or 3 in question 9, which specifically asks about suicidal ideation. Now, you can still diagnose depression if there's elevated scores in questions past question 1 and 2. But something to at least consider is that there are confounding factors that can affect positive screens in the other categories such as appetite, energy, sleep, and concentration. One of the greatest things that we see in teenagers is cannabis abuse and cannabis use that can cause disruptions in all four. Someone with cannabis use and these symptoms may be considered to have a drug-induced or drug-associated mood disorder, but not a separate diagnosis of major depressive disorder unless they had had a period of sustained sobriety and were still having those symptoms. So PHQ-9 does ask questions about suicide. However, it is not considered to be a reliable independent suicide screening tool. If there are yes answers to the suicide questions, that needs to be followed up with the use of a suicide screening tool such as the Columbia Suicide Severity Risk Assessment. And at the bottom here, you have kind of a generalized, a very general association of the depression score with the severity of the depression. So obviously, you know, our clinical expertise still comes in importance here, because if someone just really has a very poor insight, or they just don't want to fill out the form and they hit 0 for everything, but then they say that they're suicidal and acutely suicidal, we're still going to worry about that patient, whether or not they have a low score. But this can kind of guide you not only with screening for depression, but if you are treating for depression with, say, a medication, or you've set someone up with therapy, you can kind of use the PHQ-9 score as a gross way to monitor for improvement or worsening. So, antidepressants, SSRIs, they work. In the largest study that we have of adolescents with depression, or the TAD study, the Treatment of Adolescents with Depression study, they looked at teens with moderate to severe depression, and the most effective treatment was the combination of medication and CBT or medication alone. You'll notice that CBT, which in this study was actual CBT, actually doing cognitive behavioral therapy on a regular basis with people who know how to do it, it didn't really separate out from placebo for a while. Now, when they extended the study, they found that CBT eventually caught up to Prozac, but it took about twice as long to work. They saw an effect at about 16 weeks. So, if we decide to use a medication, what should we use? Well, FDA approval, we'll talk about it. It doesn't have to be the be-all, end-all, but it does generally guide our choices in what has been deemed as safe in the pediatric population. For major depressive disorder, the 2 medications that are approved are escitalopram from ages 12 to 17, and obviously above 17, and fluoxetine from ages 8 to 17. Obsessive compulsive disorder is one of the only other disorders that has a lot of choices as far as things that are FDA approved for use. You'll notice that clomipramine, fluoxetine, fluvoxamine, and sertraline are on this list. One of the things that's kind of interesting is that sertraline, though we see it used a lot for depression, there aren't a lot of really strong studies showing that it's an effective antidepressant with respect to depression in younger kids. We do have evidence that it's very effective for anxiety, as we'll talk about in a little bit. So one of the things we're running into is that we see a lot of Zoloft being prescribed, sertraline being prescribed for what we call off-label use. Meaning if a child's coming in with depression, not necessarily anxiety or OCD, they're being placed on sertraline, which, you know, it's fine. It's just if you're going to recommend it, it should be something that you mention to the parents, is that it is an off-label use of the medication. And quite honestly, most things in pediatrics are. What is not FDA approved? Paroxetine. So in 2003, before there was a black box warning, um, paroxetine, the makers of paroxetine came out and said, uh, this we're noticing problems with this medication in our patients, and the FDA actually recommended initially not all SSRIs, but just paroxetine not be used in children with major depressive disorder. So, to my knowledge, there's never been shown, it's never had a positive study of effect in any study done on pediatric patients. And it does, in some studies, have a relatively higher risk of inducing behavioral changes, mood swings, and deterioration with respect to suicidal ideation in children. It is not something that we use. We see a lot of it coming out of use in primary care when practitioners are used to seeing adults. Children are not little adults. We do not use the same medications in them. Citalopram. So it's still fairly frequently used off-label for depression, but does not itself have FDA approval. Two of the studies used to get the FDA approval for escitalopram were actually done on citalopram, which is just the older version. Escitalopram is just kind of the cleaner version of citalopram. Venlafaxine or Effexor, in 2003, it also had a warning, but it came out from its own manufacturer, warning providers against the use in child and adolescents. It does not have FDA approval. There was a second study called Tordia, the treatment of resistant depression in adolescents, that showed that in order to use Effexor, you need to have 2 failed trials of SSRIs at a therapeutic dose for a therapeutic period before considering something like venlafaxine. Bupropion, duloxetine, mirtazapine, and buspirone are not FDA approved in children for major depressive disorder. Duloxetine does have FDA approval for treatment of generalized anxiety disorder in children. It is still not first line, and we'll kind of talk about that in the next lecture. So when you decide to start a medication, you want to start low, go slow. But I would say, especially with certain medications like sertraline, you don't want to go so painfully slow that you never actually get the child to a therapeutic dose. The typical starting doses, at least for adolescents, in fluoxetine is 10 milligrams daily for 3 to 7 days, and then increase to 20. And then once they are on 20, that's when the clock starts for them being on what could be a therapeutic dose. So the 4-week check-in as to whether or not they're noticing any benefit doesn't start when you started the 10 milligrams. It starts when you started the 20. In escitalopram, in young children or really tiny adolescents, start at 5 milligrams per day for 3 to 7 days, then increase to 10 milligrams. And then in older adolescents, you'll frequently increase to 20 milligrams a day. So typical starting doses for off-label use, again, these are the off-label use medications that we still use in the child and adolescent population, are citalopram, 10 milligrams daily for 3 to 7 days, then increase to 20. Sertraline, 25 milligrams daily for 3 to 7 days, then to 50. Just to give you an idea of therapeutic range, probably the bottom dose that you're going to see be effective for depression in adolescents is 50, and you're going to usually end up with someone on a range of 50 to 100 milligrams if they're just depressed, and between 75 and 125 milligrams for mild anxiety, and up to 200 milligrams for severe anxiety. So when patients come in and they tell me that they've been on 12.5 milligrams of sertraline for 6 months, they've essentially been on placebo. Liquid formulations can allow for lower doses if you're giving it to a very young child, or more flexible dosing. I will say that in considering, giving this because a child refuses to take pills, they might consider taking pills after trying some of these liquid formulations. So these, especially if you have somebody that just cannot tolerate pills, like someone on the autism spectrum or something like that, you might want to consider using a compounding pharmacy if possible. I like to train people to take pills using the little mini M&Ms, the itty bitty ones, and then you work up to your regular M&Ms so that they can take their medications in pill form. So, what are some advantages and disadvantages of some of these medications? Fluoxetine is really a nice medication for teenagers because very rarely do teenagers have a set wake up time and bedtime, and sometimes wake up time might be several hours later. On the weekends, and if they're on something that's shorter acting, they might have a headache when they wake up or have some withdrawal symptoms. But fluoxetine has a really long half-life, so it gives them a little bit more wiggle room as far as when they're taking it. It's also low cost. It's usually on the $4 per month prescription medication plan in several different stores now. Escitalopram, it's nice because you don't really have to worry about the titration, especially if you're worried about someone's transportation. They can't come back and forth a lot. Of course, now we're doing a lot of telehealth, but when you're talking about titrating someone to somewhere between 25 and 175 milligrams of sertraline, but with escitalopram, you're either 10 or 20. So it makes it a little bit easier to get to where you need to get to. It's helpful in medically complex patients because it plays well with others. It doesn't have a lot of interactions. Fluoxetine does have more drug-drug interactions, and you have to be mindful of that. Citalopram, this one's the off-label one, remember. It has minimal side effects. It's low cost. This is also one that's usually on the $4 generic list. It does have a shorter half-life, but still seems to work pretty well. And it's very controversial as to whether or not it is clinically significant in its increase of the QT interval on EKGs at doses of greater than or equal to 40 milligrams per day. Initially, when those studies came out, a lot of people who were stable, everybody kind of had some anxiety and pulled people back to 40 milligrams from higher doses or just refused to give a higher dose. And what we saw was that there were people who were just really struggling because of that happening. So, while that's not necessarily where we aim, it also, has to be a clinical consideration with the child and whether or not they're doing well. So advantages and disadvantages to sertraline, which again is off-label for use in depression in children, are that it's low cost and it can be helpful in anxiety disorders. Disadvantages are really that it's questionably helpful in depression in the absence of anxiety issues. It has a shorter half-life and GI side effects are more common. This can be an issue because a lot of kids that do have anxiety have a lot of somatic symptoms. So that if someone really has a lot of chronic belly pain, belly aches, I do sometimes start sertraline at a really low dose, like 12.5, just to get their system used to it so that I know that if they're complaining of a bellyache, it's probably just their usual bellyache and not something from the sertraline. A lot of those side effects are very short-lived as well. For venlafaxine, there are minimal to no advantages to prescribing that for depression. Again, unless a patient has failed 2 full-length trials of an SSRI, because of course venlafaxine is an SNRI, within their treatment course, they again had to fail 2 trials at a therapeutic dose for a therapeutic amount of time before we consider venlafaxine. Disadvantages, it has more side effects, it can elevate the blood pressure, and if you're late taking your pills or you forget your pills, you go to an overnight and you forget your medication, you can get fairly ill from withdrawal symptoms. Bupropion, Advantages, it's questionably beneficial in ADHD. Um, there was one very small open label study showing that it might be helpful in ADHD, and everybody kind of jumped on the bandwagon and said, let's give it for depression and ADHD. Not helpful in that, a lot of ADHD kids are much more likely to sustain head injuries, and bupropion lowers the seizure threshold. So what we will see in the hospital is, and have seen, are patients who have head injuries who seize with much lower degrees of actual injury than one would anticipate because they're likely also on bupropion. The dosing's not as flexible. It is not helpful for anxiety. In fact, many would say it usually makes things worse, and is contraindicated in eating disorders or anything that really affects the absorption of medication, like a Crohn's disease or other bowel issue. And again, it lowers the seizure threshold. The other thing that I would say is that if you do use a medication like bupropion, or if someone in the family is on it, please make sure all of these medications are locked up, and so are the over-the-counter medications in the house. But a child can seize after taking just a couple bupropion, and a teenager can seize after just a few. So it really can be very dangerous in overdose at even a small amount. So half-lives can be shorter in children, and some medications maybe need to be dosed twice a day, like Celexa or Zoloft. It's not something that's usually done, and someone will be kind of rolling their eyes if they see that you put somebody on Prozac twice a day because it has a really long half-life, and that's just not a thing. Um, Withdrawal and discontinuation symptoms, like if, a rookie mistake is people feel better and they think that they're good, just like if you would take an antibiotic and your throat's not sore anymore, and why do I need to finish it? If they abruptly stop these medications, they can get quite ill. Irritability, flu-like symptoms, a rebound depression, fatigue, and especially with medications like the SNRIs, like duloxetine or venlafaxine, they can get electric shock sensations. They can feel like somebody has a cattle prod and is kind of poking their extremities. Not very pleasant. So response time for depression, some report improvement in the first several days. Sometimes it can be up to 6 weeks for the first response and up to 12 weeks for a sustained response. If anxiety is also present, one of the things we'll talk about is it takes larger doses for longer periods of time to see a good response. You definitely want to check in with patients, a week or two after starting the medications just to kind of see how they're doing. But you really don't want to increase the dose after that that initial increase after maybe the first week, um, unless you've given it a couple of weeks. So if at 4 weeks there is a partial response, you increase the dose a little bit. If nobody's noticed anything after 4 weeks, then you can first look at the dose. And if you have somebody on a ridiculously low dose of medication, remember that doesn't count. They have to be on a therapeutic dose for 4 weeks. Or say they thought they noticed an improvement, but it's minimally responsive after 8 weeks, or they're still depressed after 12 weeks. Of those who don't respond to an initial antidepressant, over 50% will respond to a second. The progression that the spiel I give parents and kids is that first couple weeks, you probably won't notice anything. And that's great because that means you're not having any side effects. After about 3 or 4 weeks, your parents should start thinking that you're maybe a little less snippy, you're out of your room more, maybe you're maybe attending to your appearance or your hygiene a little bit more. Nothing too dramatic, but definitely noticeable. And you won't notice anything because you just won't have that insight. And so between 4 and 6 weeks, you guys are going to argue about you wanting to stop the medication and your parents wanting to keep it on because they think it's working and you think it's not. And then at about 6 to 8 weeks, you're going to be able to look back on how you were feeling a month and a half ago and realize that you actually are feeling better. This isn't going to be an overnight fix. It's not going to be a drastic difference that you wake up one day and you're like, thank goodness my depression's gone. It's going to be a gradual change. You know, depression gradually happens and it gradually fixes. So these are not medications that work quickly and you have to give them a chance. So how long do you keep them on after you treat that first depressive episode? So the recommendation is to keep the medication on not 6 to 12 months after you start it, but 6 to 12 months after remission. So after they're doing well, then the clock starts to consider when to stop the medication. You never say, oh, you're doing better, you probably don't need it anymore, and take it off. Patients that are involved in cognitive behavioral therapy will generally have a more sustained response. And those who are treated up front and during the first major depressive episode with more robustly with medications and therapy are less likely to have a second episode. And if they do have a second episode, it tends to be further out and less severe. And discontinuation symptoms, if you are going to stop the medications, you don't just rip them off. You've got to kind of sneak them out slowly. Fluoxetine can self-taper, but what I see a lot when people are like, oh, you can just stop taking it, it'll taper out of your system in a couple weeks, is that it really still does need tapered. You know, maybe even every couple weeks, because when they go from taking, let's say, 40 milligrams of fluoxetine and suddenly 3 weeks later they're on nothing, that's quite a shock to their system, and sometimes they decompensate. So other adverse effects are much more common than the black box, but they get overshadowed. So changes in alertness. If it makes you less tired, take it in the morning. If it makes you tired, take it at night. It doesn't matter when you take it, just take it at the same time every day. Appetite, sometimes there's an increase, sometimes there's a decrease. In general, the SSRIs are considered weight neutral. That doesn't mean that different people can't respond to them differently. Gastrointestinal symptoms, nausea, constipation, dry mouth. Again, those are usually within the first week or two, and they usually kind of abate. Restlessness, kind of the activation feeling, sweating, headaches, and sexual dysfunction. Mania, true mania, when people come to me and they're like, oh, I'm bipolar. And I say, what is the longest you've ever been awake in your life without trying to stay up? And they say, well, maybe like till 3 a.m. They are not bipolar. They have irritability, and that is pretty common in adolescence. True mania, where you're going to be up for 4 to 7 days, awake and doing things as if driven by a motor, having psychotic symptoms. It's exceedingly rare. And in response to just having this, in response to starting a medication, incidence is way under 1%. Some studies have indicated that SSRIs may induce mania, but the incidence is too small to be statistically significant. Unlike some of the other symptoms, this is delayed. It's usually a couple weeks after they've been on the SSRI. And it's racing thoughts, speech, decreased need for sleep, taking micro naps, 30 minutes at night, but you're still going. Saying they're God, seeing things. That's real mania. And development of activation or manic symptoms while on the medication does not necessarily mean the child has bipolar. By definition, it's medication-induced mania, but that probably means they're at increased risk of a future diagnosis of bipolar. Behavioral activation is common and occurs in kids at a rate of about 5%, and it's reversible with discontinuation. So they're still sleeping, but to give you an example, I had one very, very cute first grader who went from being very socially shy to walking around the different stations in his classroom like he was at a cocktail party, chatting everybody up, and his teacher called his mom and said, like, what is he on? So, he got really revved up on some fluoxetine. We changed it over to citalopram, and he never had another issue. There's a rare risk of increased bleeding. It may be relevant if surgery is planned or if you're on other anticoagulants or you take a lot of anti-inflammatory drugs. It can make you a little bit more prone to nosebleeds and things like that. It's a rare risk of serotonin syndrome, but usually it's an overdose or in combination with other serotonergic meds. So if somebody is really on a lot of polypharmacy at baseline, like say somebody has cystic fibrosis, they do get put on antifungals and antibiotics that can directly elevate the levels of serotonin in the blood. And it's really important that the pulmonologist be aware that they're on an SSRI. So certain SSRIs or the antidepressants have potential to prolong the QTC interval. Really, the most likely problems are in people with a baseline prolonged QT or someone who's on a lot of other medications, especially if you have someone who's chronically ill, like a cancer patient, and they're on methadone. Methadone is probably the worst offender or one of the worst offenders for prolonging QTC. So you have to be very, very careful about what antidepressant you start them on. So in the TAD study, the side effects that had greater than 2 times incidence, meaning like they were twice the rate of placebo, were abdominal pain, insomnia, somnolence, and vomiting. And these are some of the other ones that were noted. Bruxism is the grinding of the teeth. So as an aside, sometimes after you put somebody on an SSRI, if you go up on a dose and they are suddenly complaining of headaches, ask them if they're grinding their teeth at night, because sometimes it's a bite block that they need rather than a new medication. So the black box warning, it has been dialed back a lot from where it was in 2004, but I place it here for you to be able to read. I think that the biggest things to notice is that they've changed it to say depression and certain other psychiatric disorders are themselves associated with increases in the risk of suicide, and patients of all ages who are started on an antidepressant therapy should be monitored appropriately and observed closely for clinical worsening, suicidality, or unusual changes in behavior. Families and caregivers should be advised of the need for close observation and communication with the prescriber. If you look at the original black box warning, it is much more directive and harsh, saying like you need to have follow-up, after 1 week and after 2 weeks and really laying it out. I think things have been dialed back significantly. So the black box warning was based on a review of 24 short-term randomized controlled trials with SSRIs in children for any indication, depression, anxiety, whatever they were giving them to. The review found that was a twofold increased risk of suicidal thoughts or behaviors while taking an SSRI versus taking a placebo. And there were no completed suicides. And if we look at the risk, it says 4% risk of suicidal thinking with an antidepressant, 2% risk of placebo. I think there's a problem with this that we'll talk about, which is if you look in the TAD study, pretty much every group started out with about 30% having suicidal ideation at the beginning of the study. There have been several large studies showing no correlation between antidepressant use and completed suicides. Rating scales indicate decline in suicidality with medication treatment, and increase was found with the spontaneously reported suicidality, meaning they walked in and without anybody asking them, they said they were having suicidal thoughts. The number needed to harm is 112, so 112 patients for one to have the side effect. And the antidepressants have been linked to a decrease in the suicide rate Not all. My mentor, Doug Gray, at the University of Utah, is a suicidologist and demonstrated that almost all youth in the study of 100 and I believe 130 completed suicides over the course of 10 years um, had even the ones who had been prescribed the medications were not taking them. So they looked at completed suicide, and in the retrospective profile, the children who completed suicide, who actually took their own life, were either not in treatment or not adherent to treatment, i.e. not taking their medications. Population studies in multiple countries have demonstrated an overall drop in suicide rates with the introductions of the SSRIs. So again, with the TAD study, I brought this up a little bit ago. At baseline, 29% of all of the teenagers in the study reported suicidal thoughts, and 1 out of 5 had already exhibited suicidal behavior. So you would think that with the 4 arms of the group being placebo, therapy, pills, and pills plus therapy, that if pills were causing an increase in suicidal thoughts and behaviors, you would see worsening. But actually, the measures of suicidal ideation improved in all of the groups, and the greatest improvement was in combination treatment with meds and therapy, and there were no completed suicides. So the black box warning was very problematic because untreated depression can increase suicide. And after that warning was issued in 2004, antidepressant prescriptions to pediatric patients declined 10% overall and 40% in primary care. And if you the more concerning issue is that even the diagnosis of depression in pediatric patient declined 44%. Why? Because if you identify it, then you have to do anything. You have to do something about it. So those diagnosed with depression, when we actually did diagnose it, they're 3 times less to get a med, and there was no increase. It wasn't like they were not getting medication, but they were getting more therapy. There was no increase in therapy. And for the first time in almost 20 years, the suicide rate increased 18% from 2004 to 2005. And it said the first increase in 10 years, but it was actually longer than that. So how do you monitor SSRIs after you stop them? You monitor them closely when starting, stopping, or changing the doses. The FDA in the original black box warning used to recommend weekly for a month and every other week until symptoms resolved, and then every month. But now, of course, you saw the recommendation has changed to monitored appropriately and observed closely during the initial few months of treatment. So usually we recommend at least a phone contact within 1 to 2 weeks of starting the medication, reassessment at 4 weeks, and then usually in 4 to 6 weeks intervals. So you screen for new suicidal thoughts at every visit. You can also rescreen a PHQ-9 just to kind of see where their trends are going. Height and weight, you always plot growth at every visit. You want to look for weight gain, weight loss. Ask about easy bruising, bleeding, sleep issues, irritability and agitation. Restlessness every visit, but especially at week 2 and after 4 to 6 weeks, just to make sure you're not winding up to a mania. And again, consider using the rating scale to monitor your progress. And you can do the PHQ-9, have the patient and parent do the PHQ-9 in the waiting room so it doesn't take extra time in the appointment. So documenting consent or refusal. So this is one of the smart phrases that I use when I prescribe an SSRI, and I just kind of tweak it to what we discussed, or if I added something or we didn't really talk about something. It says discuss the risks, benefits, and alternatives to the use of antidepressant medication, as well as the expected outcomes with and without medication. Discuss the possible risk of suicidal thinking and behavior in children and adolescents treated with antidepressants. It is better to put this than discuss the black box warning, because what has happened is that parents have come back and said, well, I didn't know what that meant. Also discuss risk of behavioral activation as well as physical complaints such as headache or upset stomach. Guardians expressed understanding and provided consent to begin treatment with a medication. Now, I am of the thought that, we know that there is robust evidence showing that these meds work, and that standard of care needs to be treatment at least with a medication, and ideally with medication and therapy for moderate to severe depression. So I worry about kids not being placed on medications and the effect that it has on their treatment course. So if a parent declines to start a medication that I'm recommending, I also document that I recommended that the patient be placed on an SSRI as the most effective and robust treatment for moderate to severe depression in teenagers is that of combined treatment with psychotherapy and antidepressant medication. Patient and parent have opted to decline initiation of an SSRI at this time, but are strongly encouraged to revisit this option if the patient's symptoms do not improve or worsen in the near future. And these are